And I'd like to introduce Dr. Ross. She's the Medical Director of Clinical Research Affiliations Network at VCU Massey Cancer Center and VCU School of Medicine. She is also the Medical Director of Massey's Integrative Health Program and an Assistant Professor in the Division of Hematology, Oncology, and Palliative Care, Department of Internal Medicine at VCU School of Medicine. Ross joined VCU in 2011 for her internal medicine residency, then completed a hematology oncology fellowship and joined the faculty in 2017 as an assistant professor. She earned a medical degree from Loyola Stritch School of Medicine and a Master's of Science in Integrative Health from Georgetown University. She is a member of the American Society of Clinical Oncology and the Society for Integrative Oncology. Dr. Ross sees patients at 3 different locations: the Hendrick Cancer Center in South Hill, the Adult Outpatient Building in downtown Richmond, and at Stony Point in Richmond. So I will turn it over to her.
Great. Thank you, Christy, for the introduction. And thank you all, everyone that was able to join this afternoon. I am going to share my screen. Okay. Does that look okay, Christy?
Perfect.
Okay, good. So I'm Macy Ross. Thank you for the introduction. And what I'm hoping to share with everybody today is just a breast cancer overview. I'm going to talk for 15 or 20 minutes, and then we'll have questions, time for questions or discussion at the end. So please put that information in the chat. And this is intended to be very informal. I'm happy to add things or subtract things if people want to talk about something specific. But this is what I put together for today as a learning objective. So we're going to go over some breast cancer statistics, just some data about incidence of breast cancer and generally how people do when they're diagnosed with breast cancer. We'll go over some risk factors, signs and symptoms of breast cancer. We'll talk about screening and diagnosis. We'll talk a little bit about prognostic factors because not all breast cancers are alike. In fact, they're very different. And then we'll talk about some treatment options that may be recommended depending on an individual's cancer. So just some statistics I wanted to share with you all. This is from the SEER database, which is a National Cancer Institute Surveillance, Epidemiology, and End Results Program. And they publish a lot of statistics on different types of cancers. And so what we know from the database is that breast cancer is the most frequently diagnosed cancer worldwide. It's the most common female cancer in the United States, with an estimated number of new cases in 2022 over 287,000. And that represents about 15% of all new cancers that are breast cancers. Women tend to do very well when they're diagnosed with breast cancer, and you can see that this is sort of the average 5-year survival here at the bottom. So over 90% of women, are alive and well at the 5-year mark, even after diagnosis. And even though the rate of new cases remains high, you can see on this graph here in the middle that the death rate continues to go down over time. So compared to back in the 90s to 2020, the death rate is going down. And this is likely a result of new treatment options, but then also breast cancer screening and earlier diagnosis. And this just shows the same thing that was in the last graph. In addition, the 5-year relative survival over time, if you look back in the 70s, this curve continues to go up. So most women with breast cancer do very well over time. In terms of risk factors for breast cancer, there are a lot of different things that we think about. Some of these things are what I've categorized as modifiable, so things that we may have some control over. And then some of the risk factors for breast cancer are things that we don't have as much control over. So these are non-modifiable risks. And so those non-modifiable risks would include things like age. So the risk of breast cancer does increase as a woman ages. Being a female is a risk factor in and of itself. Race, so white women or Caucasian women are at higher risk of developing breast cancer. There are certain things particular to a woman's breast that can increase the risk. So if she has dense breast tissue or what we call proliferative lesions, so this means, oops, sorry about that. Proliferative lesions are things that may have been diagnosed on a woman's breast, but they're not cancer in and of themselves. So if a woman has ever had a prior biopsy showing either atypical ductal hyperplasia or lobular carcinoma in situ, again, these are types of benign lesions in the breast, but they can increase the risk of subsequent breast cancers down the road. There are also reproductive factors. So this has to do with cumulative exposure to estrogen over a woman's lifetime. So if a woman starts menstrual cycle, her menses early at a very young age, or if she goes through menopause at a very late age, she's considered to be at higher risk for breast cancer. And similarly, you'll see down in the modifiable risk category, if a woman takes hormone replacement, obviously that also increases the exposure to estrogen. So that is another category of risk factor. Having a family history of breast cancer can increase an individual's risk. So if her parent, if her mother was diagnosed with breast cancer, or sisters, grandparents, things like that. And there can also be associated genetic mutations, which can be hereditary. And the most common one that people think about, I think that is most common and also talked about in the news, is the BRCA mutation. But there are many other types of genetic mutations that can be inherited and passed through families as well. And I've listed some of those here. Modifiable risk factors, like we talked about, hormone replacement therapy does increase the risk of breast cancer. Being obese also increases the risk. And especially in women who have already gone through menopause, being obese or having a body mass index over 30 is associated with increased breast cancer risk. There's data that shows that alcohol consumption can increase the risk of breast cancer. And then down here in the other category, I put exposure to ionizing radiation. And what I mean by that is if a woman has had to have chest radiation for some reason, at a younger age, for example, if a woman had lymphoma and had to have radiation to the chest, then that increases her risk of subsequent breast cancers. Signs and symptoms of breast cancer. So the most common thing that we think about is a breast mass. So if a woman feels a new lump or bump in her breast, she should see the doctor, see her doctor, primary care physician, gynecologist, whomever, to examine the breast and then, move forward with further evaluation. Most often we think of breast cancers as being hard. They may be immobile, but they may not be. So really any new change in, a breast lump or a breast mass should be evaluated. Change in breast size or shape can also be a sign or symptom of breast cancer. So even if a woman's not feeling a particular lump or bump, if she has noticed that the breast has started to shrink over time, become more shrunk in appearance, or on the opposite end, if she notices that her breast is becoming more large or engorged, she should have that evaluated as well. And then most commonly when breast cancer if breast cancer starts to spread outside of the breast, the first place it goes are these lymph nodes under the armpit. So if a woman has a lump or a bump or a change in the contour under the armpit, which I've put here as palpable lymph nodes, that should also be a red flag that she needs to be evaluated to see if there's something going on. This slide shows some of the skin findings that can be a sign or symptom of breast cancer. So certain types of breast cancers can present with warmth of the breast, of the skin, redness, you can see dimpling or puckering, and there's a terminology called peau d'orange. And so if you look over here in these pictures, that just means peel of an orange. So some breast cancers can actually present with thickening of the skin, and you can see this dimpling appearance where it looks almost like an orange skin or a citrus skin. Nipple change should prompt further evaluation. So if your nipple is normally everted or outward shaping and suddenly it becomes inverted, or if there's puckering of the skin, Any bloody nipple discharge or scaly swollen lymph nodes should prompt evaluation. And then if a woman has breast cancer that has spread outside of the breast or the lymph nodes, then signs or symptoms of that would depend on where that breast cancer has spread. And for breast cancer specifically, the most common sites of spread include bones, followed by liver and lung. So if a woman had a history of breast cancer and she has new bone pain or shortness of breath, anything like that, that should prompt evaluation as well by their by primary care or a doctor. So screening and diagnosis, we have very good tools for breast cancer screening. Mammogram is an excellent tool, and we recommend an annual mammogram, once a year mammogram for all women at average risk of breast cancer. And I'm going to talk a little bit about what we recommend for women that are considered to be at high risk. And there is some debate in between amongst different specialties and amongst different organizations about when we should start doing mammograms, at what age. Those of us in oncology generally recommend that for women at average risk of breast cancer, a mammogram should start at age 40, or at least you should have that conversation with your doctor about starting mammograms at age 40. Mammograms have been very well studied. They've been shown to decrease mortality from breast cancer. They can identify presence of a mass or a density that might need further workup, or calcifications that might be a sign of a new cancer. Now, if a woman is considered to be at high risk for breast cancer, then the screening recommendations may change. So how do you know if you're at high risk? Well, we talked before about, or I mentioned before, some of the risk factors for breast cancer. And there are some calculators, statistical calculators, that can estimate your breast cancer risk. And so the most common ones that we think about, there's one called the Gale model, and there's one called Tyrer-Cuzick. And these are statistical calculators that you could walk through with your primary care or your gynecologist, or if you have an oncologist. And you put information into these calculators, like what we talked about before, in terms of family history, age, when you started your period, etc. And it can calculate what your lifetime risk of getting breast cancer might be. And if the lifetime risk is considered, if it's higher than 20%, then we consider that to be at high risk. And for some women with high risk that are considered to be at high risk of breast cancer, we may also recommend an annual breast MRI, a once a year MRI, in addition to the annual mammogram. In addition to the risk calculators that can help identify women that might be at high risk, other factors that might automatically put women into a high risk category is if they have certain genetic mutations, like we talked about before about a BRCA mutation would be one example, or if a woman had a prior reason to have radiation to the chest. So what generally happens after you get your screening mammogram is one of two things will happen. Either the radiologist will read it and say everything looks benign and you can get your next mammogram in 1 year, or some women may get what's called a callback after your screening mammogram. And so if you go for your screening mammogram and you get a callback from the radiologist or the staff at the radiology center, that means that additional imaging has been recommended to take a closer look at your breast tissue. And the additional imaging that typically is done is what's called a diagnostic mammogram or an ultrasound, or both. And a diagnostic mammogram is similar to a screening, but takes additional images and additional pictures to take a look at the tissue. This is not uncommon necessarily to get a call back, and it doesn't necessarily mean that that woman is going to have cancer or have something found that needs further workup. And in fact, fewer than 1 in 10 women who get called back are found to have cancer. So it is very important, if you get a call back, to schedule that additional diagnostic mammogram and ultrasound, but it doesn't necessarily mean you have cancer. It just means that you need more evaluation. You can ask, we realize that these callbacks can cause a lot of anxiety, especially if a woman has had a history of breast cancer, or there's a family history. So you can ask to be given the results of the callback right during the visit. And I know all centers might not be able to accommodate that, but many times the radiologist will be obviously involved in the diagnostic mammogram and ultrasound, and he or she may be able to give you those results right there and then at that visit, so that you're not having to think about it afterwards and wait for the letter or the call. I put down here what's called the BI-RADS categorization, and this is breast imaging reporting and data system. And so this is a standardized way that has been developed to report out findings of a mammogram. And so if you look at your mammogram report, you'll see this BI-RADS on all of your reports. There'll also be wording beside it that sort of explains what it means. But this is a standardized way that we can look at mammograms and know that the findings are standardized between individual patients. So if a woman has a BI-RADS 1, that's considered to be normal result, normal findings, nothing concerning on her mammogram. If the radiologist sees something that there's something there, maybe a mass or calcification, but it looks benign, then they might assign a BI-RADS 2. If they say BI-RADS 3, it means it's probably benign, but they may recommend repeat imaging. And sometimes a woman will have a screening or a mammogram and or ultrasound, and the radiologist might say, well, we think everything looks okay, but we should do a repeat mammogram and or ultrasound in 3 or 6 months, something like that. So they may recommend sooner imaging than the standard annual mammogram, just to make sure things aren't changing. If a BI-RADS 4 is reported, then that means it's suspicious for a cancer and should be biopsied. And a BI-RADS 5 means it's highly suggestive of cancer. And radiologists only put the BI-RADS 5 on there if they feel that the risk of breast cancer is over 95%, or the likelihood of breast cancer is over 95% based on the imaging findings. So this is just an algorithm that I put up to show what happens with an abnormal mammogram. So if a woman has an abnormal mammogram, and we talked about the BI-RADS system, if a biopsy is recommended, then we go down to this down here. And typically these will be image-guided biopsies. And so usually the radiologist will help to guide the biopsy, and either a surgeon will perform it or the radiologists themselves will perform the biopsy. And it's done what's called percutaneously. And so I've got a picture here to show what that means. Percutaneous just means through the skin. So typically this area is numbed up, and there's a small needle that's inserted into the mass to get a sampling of those cells. Prognostic factors. So once a woman is diagnosed with breast cancer, there are several different things that we're looking at. And there are different things that can impact how a woman does. And so we look at patient characteristics, we look at the method of detection, and we also look at certain tumor characteristics. So when we think about patient characteristics and what are some prognostic implications of that, we know that women who are at very young age, that can be associated with a worse outcome. And that's because women who are diagnosed with breast cancer at very young age tend to have more aggressive types of cancers. Older age can also be associated historically with a worse outcome. And that is probably may have some to do with what other medical problems a woman has when she's older, or what other things we might have to contend with as we come up with the treatment plan. There's some data that race can influence prognosis, and we know that African American women tend to have more aggressive tumor biology, and we're going to talk about tumor biology in a minute. And then other patient characteristics that can come into play in terms of how a woman does once she's diagnosed with breast cancer include other, what I call comorbidities. So again, other medical problems. So if a woman has a lot of underlying medical problems like diabetes, heart conditions, lung conditions, things like that, it may limit what kinds of treatments she may be able to get, and that could impact how people do over time. When we think about tumor characteristics, there's two main types of breast cancer, invasive ductal and invasive lobular, but there are other more rare types as well. Most of the cancers I've got down here, this picture or diagram, most cancers that we see start actually in the duct of the breast, about 70%, and 10% or so start what's called in the lobules. And then there are other types of breast cancers, again, that we see less often. We do think about staging. So staging comes into play, and more advanced stages, again, is associated with a worse outcome. When we do our staging, we now use what's called prognostic staging. So lots of tumor characteristics go into the prognostic staging, including the size of the tumor. We look at whether or not there's lymph node involvement, whether or not the cancer has spread outside the breast and the lymph nodes to other parts of the body. We know that from historical data that women with larger tumors and more lymph node involvement tend to do not as well. Now, that doesn't still mean there aren't treatment options and that they can do well, but tumor size and lymph node involvement is associated with poorer prognosis. There's also lots of tumor characteristics we look at. So all breast cancers are not treated the same, and they can behave very differently. So this pictorial that I created is looking at tumor subtype, or what we call phenotype. So there are different receptors that we look for on the cancer cells. Remember, we talked about a woman getting a biopsy, and then that biopsy will go, those cells go to our pathologists who process the specimen, and they look for these different characteristics. So they look for expression of estrogen receptors on the cell surface, progesterone receptors. They look for a growth factor receptor called HER2 that can sometimes be amplified in certain breast cancers. This graph, this is again from the SEER database, these charts, and it's showing that the proportion of women with those different subtypes. So you can see 68%, the majority of women that are diagnosed with breast cancer are diagnosed with what we call hormone receptor positive, HER2 negative breast cancer. You can see over here, this is looking at the 5-year survival rate by cancer subtype. Those women tend to do the best in terms of overall outcomes. Other types of breast cancer that we mentioned on the previous slide are what's depicted here in this dark green, which is hormone receptor negative, HER2 negative. We call those breast cancers triple negative breast cancers, and those are a more aggressive tumor type. And so you can see here, compared to the other types of breast cancers, those patients tend not to do quite as well. And then there are other types are depicted here. So hormone receptor positive, HER2 positive, we call these triple positive breast cancers. Again, you know, as a whole, most people with breast cancer tend to do very well, but there are some differences depending on the cancer subtype. And then more recently, we've started also looking at what we call gene expression profiles. So we can actually send a piece of the tumor off, either collected at the biopsy or at the time of surgery, and we get expression. We can send it to a company that measures the expression of certain genes within the cancer cells, and that can give us an idea also of what is the risk of the cancer returning at a later date, which can impact what types of treatments we might recommend. So I'll just touch briefly on types of treatments that might be recommended for breast cancer. And what type of treatment is recommended is obviously dependent on, you know, the individual person, what other medical problems she may have, what is the stage of the breast cancer, whether or not it's hormone positive or HER2 positive. But this gives you an idea of just the types of therapies that we most commonly use for breast cancer. I've got here local regional therapies. So that means local therapies. So that includes things like surgery or radiation, which is sort of directed just to the breast. And then that's contrasted with what we call systemic therapies, which include really medications. And so medications, I call them systemic therapies because they really, once they're absorbed or they are put through an IV, they sort of go throughout the body systemically. And that may include things like chemotherapy, biologic therapies. We've got lots of targeted therapies, immunotherapies nowadays, and endocrine therapy, which is really targeting that estrogen receptor for cancers that are using that estrogen to help them grow and survive. I won't go too far into the different types of treatment because, again, that's very individualized depending on the patient and her cancer. But some of the types of surgery, there's basically two types of surgery that may be recommended. One is called breast conserving therapy. So that's where the surgeon removes just a portion of the breast. And typically that also includes an evaluation of the draining lymph nodes to see if those may be involved. And then for some women, a mastectomy may be recommended if she's got a larger tumor or there's multiple areas of tumor or based on patient preference. Radiation, there's different types of radiation that may be recommended. So there can be whole breast radiation, or there can be more of a targeted type of breast radiation called accelerated partial breast radiation. And then in terms of chemotherapies, and immunotherapy, sometimes those are recommended before surgery. We call that neoadjuvant, or sometimes they may be recommended after surgery, which we call adjuvant. Again, that depends on the tumor type, the tumor size, patient characteristics, etc. And endocrine therapy is really only recommended if a woman has an estrogen sensitive or estrogen progesterone positive cancer. And many times those are generally pills, and many times those will be recommended for several years after a woman's diagnosis. For women who have metastatic cancer, again, that means that it's spread outside the breast and the lymph nodes. The primary treatment usually in this instance is more of a systemic therapy. So again, therapies that are absorbed and go throughout the body. So that may include chemotherapies, immunotherapies, endocrine therapies, or other targeted drugs. The goal in this instance is usually disease control, so rather than cure, and also to help prevent and control symptoms and prolong life. Sometimes radiation is used in this instance mainly for symptom management. So if a woman has, for instance, an area in the bones, a cancer in the bone that's causing a lot of pain or discomfort, sometimes radiation will be used to help with that. And I think I'm almost at time, and I want to make sure we have enough time for questions too. So in summary, this is what we kind of talked about or reviewed today. And I did want to also list here some helpful resources. So there's a lot of information online, but you really want to make sure when you're seeking out that information that you're going to very reputable sites. And so I've listed here the National Cancer Institute, American Cancer Society, American Society of Clinical Oncology. The national NIH has a lot of different websites on cancer, as well as integrative therapies for women that are interested in a holistic approach. And then this is the VCU Massey Cancer Center webpage as well, that has information about breast cancer, about our team, about clinical trials that a patient might be eligible or interested in. And I think that concludes our talk. And I'll be happy to take any questions or comments. Thank you.
Thanks, Dr. Ross. You all can put your questions in the chat or just unmute your microphones and ask. I don't see anything in the chat, so thank you very much for your time today. We appreciate your expertise and sharing with us during Breast Cancer Awareness Month.
Yeah, it's my pleasure. Thank you all for joining.
Thank you very much.